Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will discuss about laser peripheral iridotomy. So laser peripheral iridotomy is one of the important procedures in the management of glaucoma, and it is a OPD based procedure. So it's very important to know in detail about the laser peripheral iridotomy. So in this video we will discuss about the laser peripheral iridotomy under the headings of the indications, contraindications, what is the technique or the procedure of the laser peripheral iridotomy, what are the complications associated with, in brief about the surgical peripheral iridectomy. Okay, so without much delay, let's begin our video on laser peripheral iridotomy. So what is laser peripheral iridotomy? So this is a procedure where we are creating an opening in the peripheral part of the iris to control the IOP. This is the definition of LPI in very simple words. Okay, so you can create a opening in the iris either by using laser or you can do it by surgery. So when you are using the laser, you are just creating a hole. Okay, there is no excision of the iris. So this is called as iridotomy. That is laser. Since we are doing it in the peripheral part of the iris, it's called as laser peripheral iridotomy. Similarly, you can also create an opening in the iris by doing surgery. That is called as incisional iridectomy, where you are actually excising some part of the iris. Okay. If you look into the history of peripheral iridotomy, von Greffe for the first time in 1957 did incisional iridectomy for many cases of glaucoma. In that, some responded and some didn't respond. Okay, so that was the first attempt for peripheral iridectomy. And in 1920, Curran did this incisional peripheral iridectomy only for the cases of pupillary block, and most of the cases responded to the treatment. So they started understanding the mechanism of the pupillary block and how this incisional iridectomy is working. And in 1956, Mayer Schwickerath used xenon arc photocoagulation to do the PI. The incidence of the corneal burns and the lens opacities were little high. And the major breakthrough or the advance happened in 1970s when the argon laser was used and it was adapted to the slit lamp for the treatment of glaucoma. And in 1980s, with the advent of the Abraham lens, the laser PA gained more popularity and the treatment was more successful. So this was in brief about the history of laser peripheral iridotomy. So before going to the indications and the contraindications of laser PA, let's see how this peripheral iridotomy works. Okay. So normally what happens? The aqueous is produced by the ciliary processes of the ciliary body. So it first fills the posterior chamber and then through the pupil it will come to the anterior chamber and then get drained through the trabecular meshwork. So this is the normal mechanism of aqueous outflow, as you all know. So what happens in case of pupillary block? Aqueous is not going through the pupillary aperture and coming into the anterior chamber. And in some cases of plateau iris configuration, whenever the pupil comes in the mid-dilated position, there is opposition between the iris and the anterior surface of the lens. So the aqueous gets trapped behind the iris. As the aqueous gets accumulated in this posterior chamber, it pushes the iris anteriorly. As the iris is pushed anteriorly, it forms what is known as the iris bombe. So here the iris will assume this shape of iris bombe and eventually it will block the outflow. That is, the trabecular meshwork is blocked mechanically. So the intraocular pressure will rise. So this is the mechanism of pupillary block. So by doing the peripheral iridotomy, you are creating an artificial hole or creating an artificial pupil here. So the aqueous will come through this and the normal mechanism of the aqueous outflow is maintained. So this is how the laser peripheral iridotomy or even the surgical iridectomy works. Okay. So where all you want to do peripheral iridotomy? So any case of primary angle closure, I am not using the word glaucoma here, like it may be in the form of attacks in case of acute or it can be subacute or chronic. So any case of primary angle closure, wherever there is combined mechanism glaucoma, that is both the components of angle closure as well as open angle, the plateau iris configuration as I explained just now, the pupillary block either following cataract surgery with or without lens implantation. You do surgical PA but it is not completely perforated iris, then take the patient for laser iridotomy. You can also do it in nanophthalmos cases. And one more indication is for the optical iridectomy, where you want to enlarge the pupil whenever there is the central corneal opacity. And in case of ciliary block glaucoma and the fellow eye of a person who had acute angle closure attack in the other eye. So these are the indications for laser PI. So what are the contraindications for laser peripheral iridotomy? There are very few. In case of uncooperative patient, the corneal edema which is not coming down in spite of your treatment, and the flat AC is a relative contraindication for laser iridotomy. So coming to the technique of the laser PI, so you have to prepare the patient for the procedure first. So what are the measures you should take preoperatively? First, you should control the intraocular pressure to near normal range at least. So you can use either topical anti-glaucoma medication or the systemic anti-glaucoma medication, either in the form of oral Dimox, or even you can use the IV mannitol. So you should control the IOP first. Okay, then use pilocarpine 2% eye drops at least 2 times before the procedure with a gap of 10 to 15 minutes. So make sure that the iris is stretched and it is not reacting to the light. So what are the advantages of using pilocarpine 2%? It unfolds the iris and decreases the iris thickness. So it will help to create a complete peripheral iridotomy. But the disadvantage with use of pilocarpine is it will induce inflammation. So there are more chances of developing posterior synechia. And use 1% apraclonidine eye drops 1 hour before the procedure and immediately after the procedure to tackle the immediate spikes of IOP. And use proparacaine to anesthetize the cornea. Coming to the procedure, the patient is seated at the laser instrument and examine the iris under magnification. Try to locate where the crypt is. Okay, and we can use the lenses here, that is Abraham iridotomy lens or the Weiss lens. So the Abraham lens is nothing but the plus 66 diopter plano-convex button is fixed to the anterior surface of the lens. So by using this lens, you are increasing the convergence of laser beam onto the iris. So it increases the power density at the iris. At the same time, it decreases the energy at the corneal level. So it decreases the corneal burns and increases the energy delivery to the iris. That is the Abraham lens. Or you can also use Weiss lens, which is nothing but plus 103 diopter lens. And it is 2.92 times more efficient than the Abraham lens, but it is difficult to use. So what are the added advantages of using the Abraham lens? As I told, it converges the laser beam. So the energy which is delivered at the iris is more, but at the level of cornea and even at the level of the retina, it causes the divergence of these laser beams. So the corneal burns and even the retinal burns are decreased by using Abraham lens. It increases magnification without compromising the depth of focus, and it acts as a speculum. So it holds the eyelids open and eliminates the blinking. The ocular movements like saccades and the extraocular movements are reduced by using the Abraham lens. And the solution what we use when we place the gonio lens, that will act as a heat sink, thereby it decreases the corneal burns. And the anti-reflection coating, that is ARC coating, which is used in the lens, decreases the reflection of this laser beam so that it reduces the laser energy which is used. And finally, if there is bleeding after the PI or the procedure, and if you just press the cornea with the lens, it will act as a tamponade and decreases the bleeding. So these are uses of using Abraham lens. We are using the word laser again and again here. So what are the types of laser? You can either use Nd:YAG laser or you can go for argon laser. There are some added advantages and disadvantages for both. So let's see the differences between Nd:YAG and the argon laser. So what is the mechanism of action? The Nd:YAG laser acts by photodisruption, whereas argon laser acts by photocoagulation. The power per area, that is the density of the laser delivered, is higher in case of Nd:YAG, whereas it's less with argon laser. The number of application of energy to produce patent peripheral iridotomy is less with the Nd:YAG, but it's more with the argon laser. And the size of the PI which is created after Nd:YAG is little small compared to the argon laser. And the rate of closure is less with the case of Nd:YAG and it is more with case of argon laser. And Nd:YAG laser is preferred in some patients who are uncooperative and has head tremors of the titubation. And even the bleeding is less with the argon laser, but it is little more with the Nd:YAG laser. And one more difference between Nd:YAG and the argon laser is the argon laser penetration and the effect depends upon the pigmentation of the iris, whereas with the Nd:YAG laser, the pigmentation of the iris will not matter. Coming to the settings, with the Nd:YAG laser, you can use 4 to 6 millijoules per pulse, 1 to 10 applications. On an average, with the 2 to 3 applications, you get completely patent peripheral iridotomy. So coming to the settings which we use for the argon laser, again that depends upon the pigmentation of the iris. The time is 0.2 seconds, power of 1000 milliwatts, spot size 50 micron. It needs 10 to 30 spots to create peripheral iridotomy. The other lasers which were used are the krypton and the excimer helium neon laser. Next important aspect is selecting the iridotomy site where you should do the peripheral iridotomy. So usually you choose the iris between 10:30 to 1:30 clock hours position. Avoid this 12 o'clock position because the air bubble which is created by the laser can go and block this, and even the procedure becomes difficult because of this air bubble. So you are going to do the peripheral iridotomy in this quadrant. So where exactly you should do in this part of the iris? Choose the most peripheral part of the iris. By choosing the most peripheral part, you are increasing the distance between the iris and lens, so there is decreased cataract formation. But it has a disadvantage also. The cornea can be little hazy as you go to the more peripheral part, and it can block and absorb the laser energy, leading to corneal burns. So choose the iris where the corresponding cornea is little clear. Okay. In the iris where the spot should be given. So select the crypts of the iris. Here the iris is very thin, so you can use less energy to produce the patent peripheral iridotomy. To sum up the iridotomy site, between 10:30 to 1:30 clock hour position, avoid this 12 o'clock position, go to the periphery as far as possible, just avoid the hazy cornea because of either arcus or other corneal degenerations, and select the crypt of the iris so that the iris is very thin and you can use very less laser energy to produce patent peripheral iridotomy. So now the question is how to tell that the PI is patent. So coming back to the procedure, so the patient is made to sit in front of the slit lamp with the laser connected, and the Abram lens with the solution is placed over the cornea, and the iris is selected as I described just now, and you create the hole in the iris by using the laser. Okay, so once the hole is created, means once you create a complete thickness hole, there will be gush of aqueous which is coming from the posterior chamber to the anterior chamber. How you can make out the gush of aqueous from the posterior chamber to the anterior chamber is, you can see some pigments which will be coming from the hole what you have created. And the patency of PI also depends upon the bridging fibers which are there in the iris, the configuration of the iris, and the proximity to the anterior lens capsule. You can also use retroillumination to see the glow from that iris hole, or you can directly observe the iris hole and try to see the lens capsule or the zonules through it. So if you have created the peripheral iridotomy hole here, you should be able to see the lens capsule or the zonules through it. But just the visualization of the anterior lens capsule doesn't mean that the PI is functional. Sometimes there can be 360 degree synechia of this iris to the lens. So you will be able to see the anterior lens capsule, but the aqueous will not be draining through that. So after the procedure, make sure that you see the gush of the aqueous which is coming from posterior chamber to the anterior chamber, which is appreciated with the pigment dispersion which happens there, and you can do retroillumination and confirm the patency of the peripheral iridotomy. So once the PI is done, use 1% apraclonidine eye drops immediately and start the patient on steroids. Usually dexamethasone is started 4 times a day in tapering dose, and review the patient 1 hour after the procedure as well as after 1 week. So there are chances of immediate IOP spikes. So you should examine the patient after 1 hour and make sure that the IOP is under control. And after again 1 week, you call the patient for follow-up and look for the iritis and the intraocular pressure. Okay, and you can modify your treatment plan. So what are the complications associated with this laser peripheral iridotomy? There is iritis which can be transient, or it can lead to chronic iritis as well. Increase in intraocular pressure, which is again acute or chronic rise in intraocular pressure. There can be localized corneal edema, damage to the lens. There can be burns to the peripheral retina or even to the fovea. So this can be avoided to some extent by using your Abram lens. The PI which is produced may not be completely patent. In that case, again call the patient for follow-up and do the repeat procedure at the same site. There can be closure of the peripheral iridotomy. If there are chances of closing of PI, it usually happens within 24 hours of the procedure or maximum within first month, and it rarely happens after 6 weeks of the procedure. And the most important complication is diplopia or the glare. So I told we choose the upper part of the iris between 10:30 to 1:30 position because it is covered by the eyelids, so that the diplopia is avoided. But in some cases, if you have created the iridotomy hole so that the eyelid is bisecting your iridotomy hole, there are chances of glare. Okay, make sure that your iridotomy is completely covered by the eyelid. It should not be bisecting your iridotomy hole. So these are the complications associated with laser peripheral iridotomy. So just for the sake of completion, few words about the incisional iridectomy. Okay, incisional iridectomy. As the name suggests, it is iridectomy, that is you are actually cutting some part of the iris to create a passage between the posterior chamber and the anterior chamber. So the procedure is done in OT. Give peribulbar block. You can either choose the clear cornea or you can choose the limbal area, okay, to enter into the anterior chamber. But when you approach to the limbus, you need to do some amount of the peritomy, that is conjunctival flap. You need to do the limbal based or the corneal based. So the clear corneal incisions are preferred because you are saving the conjunctiva here, where the patient may need trabeculectomy in the future, so you are not disturbing the conjunctiva. Once you do the clear corneal incision, either the iris is prolapsed by pressing the cornea or the iris is grasped with the forceps and a small section of the iris is cut. Okay, so thereby creating the iridectomy. But the complications of the incisional iridectomy are little more, like it can be incomplete iridectomy, where you are just cutting the superficial part of the iris and the posterior part of the iris is left behind intact. Okay, there can be risk of wound leak with the flat anterior chamber. There can be hemorrhages, damage to the lens capsule when you do the procedure. There can be formation of the posterior synechiae. And when you are cutting the iris, accidentally you may also excise some part of the ciliary body. There can be chance of hypotony, increased intraocular pressure as well. There can be vitreous loss also, ciliary block, glaucoma, endophthalmitis, and even sympathetic ophthalmitis in the other eye, and rarely the cataract formation. So these are the complications of incisional iridectomy. Hope this video on the laser peripheral iridotomy and the incisional iridectomy is useful to all of you. If you like my videos, please do subscribe to my channel, press the bell icon for further notifications. Please do like and share my videos. Thank you so much.